Thank you for joining us for the webinar today. We are going to start the webinar in 2 minutes in order to allow everyone time to get in. We are talking today with the Eastern Pain Association, bringing it all together, starting in 2 minutes. Thank you for joining us today for our webinar. We will now begin the program with our moderators, Dr. Christopher Garibo and Dr. Neil Mehta.
Thank you. I am Christopher Garibo. I'm the president of the Eastern Pain Association and the medical director of the pain medicine program at NYU Langone Health. I'm joined today by my good friend and colleague, Dr. Neil Mehta, who is the medical director of the Weill Cornell Pain Medicine Department. And thank you for joining us today for EPA's one-of-a-kind program, and hear it from the people that are leading pain medicine training and pain medicine during the COVID-19 pandemic. Pain fellowship program directors across the region have gotten together today, similar to our first session, where we have expanded the geography that we are covering to have a discussion on the state of pain medicine training during the COVID era at present and beyond. They'll be sharing their thoughts on the pain fellowship application process, actual pain medicine fellowship training, as well as what the lasting effects of the COVID-19 pandemic will be on pain medicine as a specialty. I would also like to thank Allergan, who invites you to stay after the director's presentation for a short injection training around the paradigm for chronic migraine. And we would like to thank Allergan for making this program possible. And please do stay after the program to get the start of your training around injections for chronic migraine. Today should be of great value to everybody in terms of we're joined by a faculty and program directors, Dr. Michael Sabia from Cooper University, Dr. David Dent from Dartmouth, Dr. Shivani Durbar-Akula from Johns Hopkins, Dr. Andrew Kaufman from Rutgers Medical School, and Dr. Michael Ashburn from University of Pennsylvania in Philadelphia. And I would like to start with having the program directors introduce their programs and themselves. We'll give them 2 minutes, and we can start with Dr. Sabia before we get into the sessions. And the first session is going to be moderated by Dr. Mehta, but I'll give the floor to Dr. Michael Sabia for a couple of minutes. Go ahead, Michael.
Okay, thanks, Dr. Garibo and Dr. Mehta for organizing this event. I agree, it's going to be of great value for the applicants and give them a little preview of what's happening in the world of pain medicine in light of the whole COVID epidemic. So our fellowship program at Cooper Hospital is on the newer side. It's been around for about 10 years now, ACGME accredited for only one position. And we've had on the average about 150 to 175 applicants for the one position. It is a true multidisciplinary fellowship training program where the fellow gets great experience. with the neurology rotation, physiatry,
Go in your calendar.
anesthesia, if that's not your primary background, radiology, and palliative care.
And just click the link. Don't click Zoom.
We have some
Just click
background
the link.
noise. If everybody can mute, please. We have some background noise. Thank you.
Good. Sorry about that, guys. So we actually have the volume for 2 accredited positions, but like most programs, funding is our #1 obstacle of getting continued funding from Center for Medicare Services. So we're pushing for a steady second position since we have 3 full-time attendings and the volume to substantiate 2 fellowship training applicants. We're hoping in the near future we'll be able to expand the program, but for now it's just one position. Thank you.
Yeah, thank you, Dr. Sabia. Dr. David Dent from Dartmouth. Dr. Dent.
Should unmute. Yes. Okay. Well, thank everyone for being here, and thanks for putting this on. I think this is a great, a great event, a nice avenue for fellows to learn about the program. At Dartmouth, we have 4 ACGM accredited positions. I think we're one of the older programs in the nation. Also, multidisciplinary program with nice rotations outside of our section within radiology, palliative care, PM&R for non-PM&R folks, airway for non-anesthesia folks, spine surgery, functional restoration, as well as plenty of time in our pain center, where we typically do in the neighborhood of 600 to 700 procedures, and the fellow will be the first in line for all of those procedures for the most part. And then seeing a nice range of clinical cases in the clinic with staff from various backgrounds. I think our program offers a nice, and just like the rest of the folks here, a nice collegial atmosphere and a nice place to be. It's a very beautiful location up here in Hanover or Lebanon, New Hampshire. So thank you.
Thank you, Dr. Dent. Dr. Shirvani Durbakakula from Johns Hopkins.
Hi, I'm Dr. Durbakula, Johns Hopkins. Thanks for putting this together. I think this is awesome that you guys have the opportunity to hear from all these faculty members and program directors at these awesome institutions. So Hopkins has 5 ACGME accredited main spots. Some years we actually have 6. So we're actually, we're accredited for up to 6. And it just sort of depends on the year if we have funding for the 6th spot, but we pretty much always have at least 5 fellows. I would say our program is really unique in the sense that we have some of the best and well-known researchers in the whole country, and some people, would say in the whole world, including Dr. Srinivasa Raja, Dr. Stephen Cohen, and you get to really learn from some of the people who are creating the guidelines and creating the procedures and doing the research, which is really amazing. For anyone who's interested in like an academic career, it's a great place to be. We also have a fair number of procedures and good clinical volume. So I think you can, really learn a lot at this program. Another really, really great thing that we have is our lecture series. So our attendings give all of the lectures, and we're really proud of that. Every single day we have lecture in the morning, so you guys get this incredible education. If you've heard of me and my education stuff, Pain Rounds is available online. You guys may have heard about Pain Rounds by this point, but if you haven't, certainly check it out. It's a neuromodulation curriculum at painrounds.org. So we're just really focused on education, and we love training new fellows, and we hope that you consider us as a program.
Thank you, Dr. Durbakula. Dr. Andy Kaufman from Rutgers University.
Unmute. So we're Rutgers, New Jersey Medical School. So we're based in Newark, not to be confused with New Brunswick. We think we're the better school, obviously. We're accredited for 2 slots, and similar to Cooper, we have 1 currently. Part of it is the CMS funding, but also in terms of clinical work, we probably have enough for 2, but we want 1 to get an enormous amount. So our fellow this year, even with COVID, still had almost 700 procedures. He just sent me his log. He had 680 procedures. And we do everything from the bread and butter, obviously, to spinal cord stimulation, pumps. The way we work our rotation is very similar to what you've heard the other directors, but we, part of our psych rotation, we've eliminated that. We actually have an addiction medicine rotation as a component of that. If you're applying from anesthesia, obviously you do PM&R. If you do PM&R, you have to do airway anesthesia. We also do neurology, we do neuroradiology. We also have a 2-week rotation through rheumatology, as well as neurology. So we are based in Newark, though the fellow also comes over to Overlook Hospital in Summit, which is more of a high-end community hospital. It's a slightly different patient population there. So you're getting to see both inner city populations as well as more of a community population. So I think it's a nice mix. The other piece is that our fellows have gotten excellent jobs all over. One's in Virginia. We have 2 in Pennsylvania and 2 in New Jersey. So that's important. We do interview both anesthesiology residents as well as physiatry residents. So we have a very brisk program. We have 3 attendings as well as 1 nurse practitioner that help to run the office. Thanks.
Thank you, Dr. Kaufman. Dr. Michael Ashburn from UPenn.
Hey, my name is Michael Ashburn. I'm delighted to be here, and I'm really very pleased with that I could join the Eastern Pain Association for this meeting. The Penn Pain Fellowship has 4 slots. We're moving to 5, hopefully next year, and the 5th slot will be dedicated towards pediatric pain at CHOP, and the other 4 will be focused on adult care. The pain program has 12 full-time faculty plus a number of other faculty that participate in the program, often on teaching or in our research mission. And we have 4 pain fellows. While we have 8 treatment locations across, from Cherry Hill, New Jersey into Chester County Hospital, our pain fellows are at our main location, which is downtown, or at the Pennsylvania Hospital Spine Center, or at Radnor, which is a program on the what's called the main line in Philadelphia. We currently are fairly busy in that we see about 2,500 patients for new patient visits or medication management a month, and we do between 250 and 300 procedures a month. Our fellows spend their time either with the outpatient pain program, the inpatient consultation service, or at the VA. And at the VA training location, that program is supervised by one of our graduates, Adrian Popescu, who's a physiatrist. They also spend time with our pain psychologist, Martin Cheadle, as well as with Catherine Hamilton, who's a neurologist who runs a headache program and does the headache and neurology portion of our training program. Again, I'm delighted to be here and look forward to participating in the rest of the program.
Thank you, Dr. Ashburn. So again, as a reminder, we're going to have 3 sessions. First session is going to be pain medicine fellowship application process, followed by pain medicine training, followed by career planning and pain medicine as a specialty. And Dr. Mehta is going to moderate the first session. Dr. Mehta?
Great. Thank you, Chris, and thank you to our panelists for joining us. Wonderful to have you here, and I know we have an eager audience. So the first session is going to talk about the application process, and I'm going to give you some questions to sort of discuss, start discussion on this. And maybe Shravani, I'll start with you. How are you doing your interviews today?
So we're utilizing the Zoom platform. You know, we're also making sure that applicants are able to discuss with our current fellows, including fellows that are just started, but also our fellows that just left. And Zoom, you know, in one way, it's obviously not the best platform, but in other ways, we've been able to incorporate fellows who are no longer here, but who have gone through our entire program. So it does allow you to really ask good questions of people who have gone through the entire program. Despite the format being on Zoom, I think we've been able to have a pretty good understanding of our applicants, and I think our applicants have gotten a fair understanding of us. I think that, you know, definitely there is opportunity for any applicants that are very interested to come and rotate with us. Despite COVID, you know, we do have a huge space. We have 13 attendings, but we also have several different sites, and between all the different sites, we can certainly get you to a place where you can rotate safely if that's something that you would want to do, and the hospital is allowing that. We have videos that we made of the pain clinic and of our as well as of some of our attendings that can also help you get an idea of what our program is like.
Great, thank you. Andrew, I think you mentioned something unique that you're doing in your interview process about meet and greet. Can you share that with us?
Yeah, sure. So obviously people can't come in the night before or really tour our institution or be able to meet with the fellows. So our former fellow who just finished came up with the idea of doing a virtual happy hour. And so he's done 2 of these for scheduling so people can get to that. And universally, when we've talked to applicants, they've really loved it because he just went through the program. He's finished, so he's gotten his diploma. We can't take it away from him. So he can really give the good, the bad, and the ugly about the program in a very informal format. And he really, truly has a drink. He says, I wanted this to be a happy hour, so it's very relaxed. And they've done it for, well, it's, when I spoke to my former fellow, Tim, one of them went like an hour and a half because people just were really asking questions and interacting. And I think that was great because by the time we interviewed people, they already had that information. And I really like that.
Very interesting. Anybody else want to talk about something unique that they're doing in their interview process? Sounds like people are using the Zoom format. Good. Maybe we'll talk a little bit about the selection process and what you think makes for a good candidate for your particular program. And maybe Dr. Sabia, I'll start with you with that.
Sure. So as I said earlier, being on the newer side, we kind of worked out the kinks the first few years of learning through our mistakes. And what we've realized is there is no primary specialty that I feel works better in the end to produce a more well-rounded, educated fellow, whether it's physiatry, neurology, anesthesia, even psychiatry we've interviewed. So it doesn't matter to us as much what your primary specialty is or a final hard raw board score number. It's more if we can really sniff out how much you want to do pain, because regardless of where you are and what state of the United States, you're going to have some bad days and you're going to have to do some peer-to-peer reviews or that patient that might be a little troublesome or giving you a hard time. So if you really want to do pain, I feel like you can work through those hard moments, and we want to ask questions on the interview and talk to applicants about their sincerity of what their reasoning is and how the field may change and how they're able to adapt. So yeah, passing your boards the first time is good. If you beat the mean on the USMLE or COMLEX, that's good as well. But I think getting through those really challenging days works much smoother when you're kind of in it to win it for the long run, because there's going to be these peer-to-peer processes and denials and patients who only want their opioids, and you know that might not be their best long-term outcome measure. So I think applicants who really want to help the patient do a lot better in the training program.
Great, great to hear that. Dr. Ashburn, one of the things that Dr. Sabia just mentioned is about opioid management, and you talked about medication management in your earlier introduction. Applicants that are coming to you, what sort of expectations do you have of them in terms of non-procedure based clinic and medication management?
I think that's an excellent question. I think that in our program, we are actually not interested or not actively looking for individuals who only want to do interventional pain. We're actually interested in trying to train individuals who want to be a pain specialist, which in a broader sense are individuals who are interested in understanding the basic science of how to diagnose and treat pain conditions, how to understand how to develop a treatment plan, and that treatment plan may include interventions and advanced placement care, but also should include medication management. In this day and age, I actually believe that many pain specialists, or most pain specialists, at least have to have a basic working knowledge of how to diagnose and treat addiction, particularly opioid use disorder, because there's a significant, whether we like it or not, there's a significant overlap between patients who have severe pain complaints and patients who have mental health issues and who have addiction disorders. And a pain specialist is going to be much more valuable to the institution they work at if they're able to participate in creating an integrated treatment plan for those folks. Now, with regard to expectations, what people bring to the program, we want to bring to the program a strong work ethic, a history of curiosity, and a willingness to work in an integrated team. I have no expectations that they're going to have deep understanding of medication management. I also don't have much in the way of expectations that they're going to know how to do procedures. That's my job and my colleagues' jobs to give them that education during the part of the fellowship. What we want is a curious mind and somebody who's willing to do the work that's necessary to make an active learning year of the year.
I think that's really well put. And I think that a lot of your colleagues on the panel today would probably echo those sentiments. Dr. Dent, how do you choose a candidate that you think is going to be successful? What stands out in your mind?
Yeah, I would echo what Dr. Sabia and Dr. Ashburn just said. They put it very nicely as far as what we're looking for as well. We're not looking for to create proceduralists. We want a nice, well-rounded person, well-rounded physician, well-rounded pain physician. What we're looking for is something unique. You see a lot of applications that are kind of boilerplate, and they're all amazing board scores, amazing references. But can you do something that makes your application stand out? And then once you get to the interview state, really know your application. And I see a lot of applications that are stellar that I'm not really sure if they want to do pain. Maybe they just wanted the challenge to get into a difficult specialty. But once we get to it, well, why do you want to do this specialty? And they're a little stuck. I want the person to have complete conviction that this is the right thing, the right specialty for them. So I think a broad experience. It doesn't have to be medical. We'll look back to see, what did you do in college? What did you have a part-time job in high school? What kind of things did you do? We look for, did you have some sort of customer service job at any point? That's always helpful, especially in our specialty, dealing with some potentially difficult patients. And also, don't have any expectations when the fellows get here as far as experience. I everyone's kind of on the ground level, and all I care about is a nice, strong work ethic and this sense of urgency that I have 1 year to tackle a lot of information, and I'm ready to get after it.
Thank you, Dr. Dent. Dr. Dubakala, you have been probably one of the most energetic and passionate teachers I've met in a long time. And how do you pick a candidate that's going to gel well with your sort of new format for teaching and learning?
Well, thank you. That means a lot to me, especially coming from you. But I think, we are looking for people who truly want to be leaders in pain medicine, and that's a mission statement program. So echo a lot of what everyone else has said. We want to know that you have a conviction to really pursue this specialty, and you have a reason that you want to do that, and that you have a goal to really make a difference in this community. So if you, have a passion for something, let's say whether that's the opioid crisis or opioid deaths rising during COVID-19, whatever that is, if it's RFA, if it's spinal cord stimulation, we want to see that you have a passion for pain medicine and that you really want to make a dent in the space. And that's what we want to do. We want everybody who leaves our program to go out there and really have an impact, and we want to make a dent in the field. So we choose people who are really enthusiastic, energetic, have a conviction, and have a plan in terms of, maybe not a plan that's really defined, but some kind of plan in terms of how they want to make an impact when they leave fellowship.
Thank you. Last question in this section. You all are in the relative Northeast, but you have very different programs. You have some urban, some very rural, large, small, single candidate or single fellow versus multiple fellows, rotations into the VA. How does an applicant know what is going to be a good format for them? And what advice would you give, having gone through training yourself? And I open that to anybody that wants to take that.
I'll jump in, Neil. Well, what we're looking for, especially because we have one fellow, we're looking for someone that, again, we want to see passion. As I always say, why do you want to leave the safety of the OR to come to a pain center where you're going to get phone calls and calls at 2 in the morning and families yelling at you? So we want that. But we're also looking to see, especially in our program, how are you going to fit in with us? You know, we're a small program, we're small people. We want to really enjoy working with someone that's going to be fitting into what our model is, where we really are trying to give, as we say, compassionate care. And so we're not looking for the block jock. We're not looking, and we're not a research center such as at Hopkins. So we want to train people who want to really put themselves out there into the community. And so that's what we're looking for in our program. So that's what we look for in the personal statement. It's like, why do I want to meet you? Why do I want to bring you in to meet you? So I want to see what clicks with that. What was special about you that I want to bring you in?
Anybody else that would care to share their wisdom about program selection and what things that resonate?
I think maybe I could say one thing. So I think people reaching out to other residents here at Dartmouth or previous graduates. We have over the years we have right close to 100 graduates. Reaching out to these folks to see what their experience was like. They have their diploma, so to speak, and they can say whatever they want. And I think they would speak highly of our program. And I think we're a pretty rural setting. You have to be ready for that. But I think that, especially in this time of COVID, it has its advantages. So if you can, deal with a small area, I think you get a really spectacular education.
That's great. Maybe a couple of you could, or you could all share where your most recent grads have gone. Have they been private practice, academics? Have they stayed in the area? Have they moved to other parts of the country? Be curious just to hear what has happened in this past year.
This is Michael Ashburn. My last year class, which included 4 individuals, one of them went off to that pesky program in Johns Hopkins. One other one, and one of them stayed with us and remained on our faculty. The other entered in private practice in California, where he was from. And the 4th actually went back to Puerto Rico, which was her home location after finishing training, to establish a pain practice, one of the first pain practices in Puerto Rico. And so it's quite varied. We actually focus, or our goal is to focus on people who become leaders in their community and try to strive to be the best pain specialists they can be. I actually think that it's difficult for individuals to know at this point in their training when they're applying on whether or not they're going to want to be academicians or private practitioners. And if we tell folks that we only interested in academics, and I'm cynical enough to think that they're all going to tell me they want in academics if they want in our program. And so what we try to do is we try to identify and select people who are going to be leaders in their community, whether they go into private practice or in academics. And about half of our graduates end up in academics and the other half end up in private practice.
Great. I open it to the floor.
So I would say, you know, I've only been at Hopkins for 3 years, but in the last 3 years of fellows, we've had almost an even 50-50 split every year. So we have certain people who are inspired to go into academics, and we have certain people who go into private practice. Amongst the people who go into private practice, echoing Dr. Ashburn, we just hope that they go out in the community and do something awesome, and that's what we've seen. So some of the great private practice doctors, Sean Lee and others who are out there, actually came from Hopkins, and we love that. And that's really what we're looking to create, leaders in the field.
Fantastic.
For our program, we haven't had anyone go into academics at this point, but everyone has taken leadership roles. And again, I echo what everyone else is saying, that we're just not looking to train someone and send them out. And what's nice with the way our program is, we have a nice, strong reputation. So people have gotten jobs in the area. We have two of our former fellows get jobs at different times in the Lehigh Valley, in the Allentown, Bethlehem area. Our current fellow really wanted to stay in the area. He was able to get a job in Jersey City with almost a brand new group of neurosurgeons and orthopedic surgeons that were looking for a overall pain management doctor, someone to do everything. So it's not that we're not looking for someone to go into academics, but if someone comes in and says they want academics, that would be great. But I didn't know I wanted academics. I started out in private practice and was recruited after I've been in practice for over 10 years to go back to academics. So if you had asked me when I was a fellow if I would be a program director and a director of a pain center, I would have laughed at you. I would have said, why would I want to do that? So you really don't know, and I think everyone's laughing, because you don't know where life's going to take you. So it's hard to make a decision. You may think you have a path, but don't think that's hard and fast.
At Cooper, we're about 80-20. 80% of the graduates have gone into private practice, 20% do academics, and most of them stay in Jersey, but a couple have ventured out, not from their primary state, moved to Florida and joined a group there. Another went to Colorado and joined a neurosurgery group there. But majority, for whatever reason, start joining a private practice and stay in Jersey.
Okay.
This is Dave Denton. I'll say we have graduates coast to coast, and we're probably a third private practice, third academics, and a third hospital based. And what we strive for is to produce a fellow that can go out and do anything. I think we have done that. We've got a nice alumni base out there that can help you navigate those networks.
Great. Well, I thank you. This will conclude session 1, and I'll turn it over back to Chris to lead us into session 2.
Thank you, Dr. Mehta, and that was wonderful. I certainly enjoyed and I believe even learned from it. So I'll start off with basically the focus here is going to be pain medicine training and optimization, and I'm going to start off with just some apprehensions about what COVID has done to pain medicine overall. I'm really curious, what has COVID changed in your training program for good or for worse, and how are you compensating for that change to maybe even improving your program? Anyone?
I always like to be first, so I'll mention a couple things. In Philadelphia, there was a significant surge of COVID, and the state government actually closed hospitals down in order to allow for them to do the surge. So in April and May, our pain program actually pretty much went to ground. And actually we did emergency credentialing of our pain fellows who are qualified anesthesiologists in order to be able to provide coverage in the airway or in the intensive care unit. The good news is that most of them did not need to deploy to those areas because the surge was modest. And at the peak of the surge, we had about 100 patients at our big hospital, which is not a significant number with regard to capacity. And we never exceeded our capacity for unit beds or ventilators. Our pain program essentially started going back to normal in May and was back to a normal schedule in June. Now, what is normal? The new normal includes all the normal protections for how to see patients in the outpatient in the era of COVID. including masks and social distancing and temperature checks and all of the like that I'm sure every institution has implemented. We also have done a significant amount of telemedicine, which is how we cared for our patients who either had opioid use disorder on MAT or patients who needed chronic opioid therapy or needed urgent visits during the time that our program did not allow in-person visits. We came used to telemedicine visits quite quickly, and the technology evolved quite quickly. But now it's gone back to the new normal, which is about 20 to 30% of my day is telemedicine, and the other 2/3 is in person. And our residents, being smart and capable and ability to adapt to changes, they've quickly learned how to look at our schedule, and they've quickly learned how to participate in a telemedicine visit and how to do normal staffing in telemedicine visits. And so it's fairly transparent, and I'm just immensely grateful for the flexibility of our residents and our fellows in providing the clinical care that we need. Our procedure volume basically went to 0 in April, slowly grew in May. We are back to over 200 cases a month in June. I think we did around 209 cases, and I'm hoping that July will end up being back north of 250 to 300 cases a month, which is our norm. So we're living around 88%. We expect a resurgence in the fall. Our hope and our institutional planning is that we're better prepared the second time around with a plus up of COVID patients, and that we will not go back to ground with the next resurgence, and that we have more ICU beds, more planning, and we'll be more facile and continue to provide care to pain patients during the time of an increased infection rate.
Thank you. Anyone else?
I'll jump in here. So in the context of COVID, you know, it was difficult in the beginning, especially since, you know, elective surgeries and procedures were on hold. And then the whole thing of having in-person lecture was difficult too, but I think it's actually provided many opportunities. So we started doing cross collaboration with Brigham and Women's as well as University of Washington every single day at noon. And we have this like homeschooling program that we've been doing where they will provide, like somebody will present a journal club or a lecture or whatever it is. And it's actually amazing because our fellows are learning not just from us at this point, but from attendings all over the country. A lot of other programs jumped onto this homeschooling program after we started it. And so our fellows now have the opportunity to learn from people that they may not have had the opportunity to learn from, you know, unless a grand round speaker was coming. And so in that sense, I think it's been great. They've been able to network with their colleagues at other programs as well. And as you know, pain is a small space, so that networking is really very important. And I think that, you know, while it's posed some challenges, it's also posed lots of opportunities. All of a sudden, there's all these webinars available to our fellows, and literally you could jump on a webinar every single night. And that certainly was not the case during my training. So certainly, you know, with the good, there's bad, but there are some really positive things that are happening, and I really want to emphasize those.
I would agree.
Any other?
I would agree with the fact that it has expanded things such as our program, and graciously we hop onto Cornell's Grand Rounds, and we've been really enjoying that. And that's been a great expansion for us, especially for a small program, since we're going on their Zoom Grand Rounds.
I was not aware of that.
You weren't aware of that?
That's great.
Talk to my former resident who's on your faculty now. We've been hopping on those, so you haven't seen us. We've been quiet, but it's been great. Wonderful. I've really enjoyed it, and I agree that we're right. Our new normal now is probably going to be 85% of what we were doing because of patient flow, because of patient safety. You know, we have to structure things. We can't have as many patients coming into the office. We need to space them out more. And same with procedures. So I'm hoping that we're going to stay where we are, even at 85%, but steady versus peaks and valleys. And I'm envisioning that we will even, you know, we're worried about the fall already with, you know, flu and COVID, but I think we'll all be better prepared. We never shut down completely, such as my colleagues in New York City who got absolutely slammed. We were not floated, our fellow wasn't floated, but my 2 junior attendings stopped really doing pain medicine, and they were doing airway work because they still do anesthesia. I don't do any full-time anesthesia, but we still function as a pain service, whether it was consults in the hospital or outpatient. So we may do, and I think it was actually very good training for the fellow, because it was seeing how do you work in this type of environment? And if you can work in that environment, you could have worked in anything.
Thank you, Andy. Anybody else? Okay, so it sounds like there's been a significant return to normalcy with respect to quality, and there's probably significant quantity as well that may get impacted. But has the mixture of your cases changed, office as well as procedural? Has there been any composition change?
Yeah, I can say something to that. So we're pretty much back to normal. The only thing that has changed for us would be the addition of telehealth visits. So we'll have a piece of our time carved out for those visits. But as far as our procedural volume is back to 100% or higher of pre-COVID, just brought in more ancillary staff to help get the patients through safely. And our clinical volume also is back to pre-COVID time. And I think just the addition of ancillary staff to help with that, with the transition of the patient through the clinic and the procedural suite has been helpful. We're back to where we were before. It's a very similar procedural mix.
Yeah, we're in the same boat at Cooper, back to full speed, the same diversity and variety of procedure and patient population, both at the main hospital in Camden and at the surgery center in Voorhees. So we're thankful that we have the staff to do the testing, interpret the results, not bring patients in for a procedure under sedation until we've gotten the results. And we have sufficient PPE now, which was an issue initially in probably April, and it got better in May and pretty much back to normal in June. But the volume, diversity, case variety is back to full speed.
Great. Any other opinions from any other panelists?
Chris, I would say we're seeing our usual type of cases, but we're still having some of our patients afraid of coming in. And I think that's been a rate limiting factor, that they want to come in, but they're still concerned about coming in. We're doing telemedicine, but when I say, look, we need you to come in, it's time to do whatever, they're still hesitant. We've had an interesting 1 or 2 patients already with COVID-related kind of neuropathy. So it'll be interesting to see where that goes right now as the months go on. So I'm going to be curious to see, has anyone else seen that? I'd be curious too, but it's been interesting, not great, but it's something a little bit new and kind of weird.
Any comments on the new COVID-related pain pathologies at our offices?
I've seen 3 at Cornell.
Yeah, we've seen a number at NYU as well. Okay, any other comments on this line of questioning? Okay, so moving on. So in pain medicine, there's a lot to cover in now. I'm very happy about being in my pain medicine fellowship program, but there's a lot to learn, from how to perform a pain history, physical, a whole range of procedures. So what's your advice to incoming fellows and future fellows on the most important skills to learn during the pain medicine fellowship? Clinical skills as well as procedural.
I would say, you know, procedures are super important. You have to have great technique to be a good pain physician, and certainly one that does interventions. However, if you don't know why you're doing the procedures, and if you don't know how to evaluate a patient, you might as well not know how to do the procedure, as far as I'm concerned. So to me, knowing when a procedure is indicated, how to select the right patients, what the diagnosis is, defend your assessment, defend your plan. Like you're a lawyer, You know, when you present to me, I want to hear a really solid assessment. I want to know exactly what evidence you have to support your assessment, and I want to know what you want to do about it. And once you can tell me those kind of things, and you understand the sensitivity and specificity of your physical exam maneuvers, that kind of stuff, then I feel like you're really equipped to get in the back of our clinic, into the procedure rooms, and do procedures. But I do think, you know, there's a lot of emphasis on learning to do procedures, having case volume, all of that's important. And I'm an interventionalist, I do STEM and all of that kind of stuff. But I also want to know that you guys are really focusing on the building blocks and the foundation.
Well said. I would agree with everything you just said.
I would actually
Any other?
absolutely agree with that too. In that, look, procedures are going to come, and I always tell the fellows when they finish, I said, you're still not a fully formed person. You know, we all experience our first year out in practice, and for those of us who've been doing it in a while in the dark ages, but you know, that first, second, third year, you're still learning, you're still developing, and you're still honing your skills. You're not fully formed at that point. But I think the purpose of the fellowship is to give a good for the basics. But if you don't understand how to get there, if you don't understand how to make the assessment to make the right choice, that's going to be what we really need. All of us want to teach. You know, the procedures are going to come. You're going to get all the basics, and you're going to get better at it as you do more. But if you don't understand how to get to that decision point, you're going to be dead in the water.
Thank you, Andy. Any additional comments? Yeah, so these are wonderful pieces of information for future pain medicine leaders. You need to have the building blocks in place before you decide what to do and how you're going to go about doing it. Being a consultant is really here key. So moving on, does your fellowship offer any organized exposure to billing and coding and how to run a practice?
I'll jump in there. So our billing and coding folks come and speak with our fellows about once every quarter, and then we'll go back through and they will audit the fellows' notes as far as looking at the charges. But we probably have in the neighborhood of 10 hours of education in terms of billing and coding. And then I have a practice management series that I go through once a month. I spent 8 years in private practice prior to being up here, and going through kind of the nuts and bolts of private practice versus an academic practice, and then try to go through that with them to get them informed of what each of those entails, and so they can further determine what they want to do.
Anyone else?
We do the same thing that I teach, and I want the residents, or the fellows, I should say, when I sit down to do bills at the end of the day, because we don't through the Epic service, we have something else. And I always say to them, you know, well, all right, what level do we do? Tell me why. Because I want them to understand the billing process. And we have our fellows sit in our monthly meetings with our biller. And we go over all the cash flow, we go over the AR, and we don't hide it, because I want them to understand what it means. So when they go out into practice, they have at least understand the language and they understand what we're looking at. So that's an important part of the fellowship for us too.
Anyone else?
I say one more thing. So we do also involve our fellows in our business meetings, and I think that's key. You know, to teach them. They're almost out. To teach them what it's like to run a small business. And to run a budget. So I think that is key. We don't keep them out of any meetings.
I really love that. We don't exactly include them in our business meetings, which now I'm thinking maybe we should, but we do involve them in our QA. And so they get to hear about the process, and if we make any changes in the clinic, they certainly get to not only hear about it, but give their input, because they're the ones who are doing a lot of this work. So if they feel like something can be improved in terms of efficiency, we have these meetings every month and they are all there.
Thank you. Any other colleagues? So we have a question that was emailed to us. It asks whether if there are any moonlighting opportunities during the fellowship.
Actually, that question came up with one of our interviewees, and I actually checked with our head of ACGME. And at New Jersey Medical School, unless there's a real hardship reason why someone needs to moonlight, it is, and that needs to go through the head of ACGME for our institution. It wouldn't be a decision of mine, but they really frown upon that in our institution. We have never had within our department one of our fellows, if they're anesthesia, moonlighting as an anesthesiologist. That's just something we don't do either. So at our institution, that's not something that's done.
So we do allow that. We don't necessarily promote it, but it's for anesthesia in-house. And I can understand, training through anesthesia and wanting to keep your skills up during the pain year. Obviously, that counts towards duty hours, and we've got to keep track of that. We don't want it to get out of hand, but can understand someone wanting to, keep their skills up, as well as, potentially if they're pretty far out there as far as PGY years, to make a little extra money.
Same
Any
at
other
Cooper.
colleagues?
Yeah, at Cooper, we have a moonlighting policy. We've had previous fellows moonlight in the operating room, count it towards duty hours. It may be averaged one shift every month or one every other month on the weekends to do like a 12-hour shift in the OR to keep their skills up. And I think it's worked out well. Same, we don't promote it, but we understand the balance of keeping your skills up, making a buck, and making a little diverse of your day-to-day pain routine and switching it up in the OR.
So similarly, we have moonlighting available to our fellows. Generally, it's at one of our satellite institutions, so like a community site, and it would kind of be on your own time. Most of the fellows who have done it, they've done like OB moonlighting, and it's been over the weekends.
So one final question is related to elective surgery bans. That may resurface with all the resurgences that are going on across the country. Does your institution close down the pain service during elective surgery bans, or are there provisions to stratify acuity of a pain procedure, for example, that still allows the pain procedure to proceed?
So there are guidelines that were actually authored partially by Hopkins, and those are guidelines that kind of stratify what you consider urgent, emergent, and elective. And based on those guidelines, you would make the decision in terms of what to do. And I think that's similar really across the country at this point.
How about the rest of our colleagues?
In New Jersey, and I'm sure Cooper had this too, we had to really go by what the governor was telling us, and it became very restrictive at one point. I'm sure Mike had the same things that we did. At University Hospital, which is owned actually by the state of New Jersey, was almost even stricter because it is a state-owned facility. So we almost did nothing at University Hospital. We were able to shift over to Overlook, which is our community-based hospital, but we still had to show the need that Shivana was talking about. We had to go through the stratification of urgent, semi-urgent, and we still had to justify everything we did. That being said, I mean, we didn't go to zero, but instead of doing 30, 35 procedures a week, we were doing 5 because that's what we were allowed during the absolute crisis in New Jersey, which was April. And I don't know what your experience was, Mike, with that, but that's what we had.
Yeah, same thing at Cooper. Only the dire straits patients that had a spinal fracture or some kind of issue that really couldn't wait any longer. And we were doing under 10 procedures a week as well, just for that month of April, maybe a week in May, but same thing. We had a lot of oversight with the government and governor and a lot of restrictions, but we're back to full speed now, but it was pretty tight there for a while.
Yeah, same type of experience at Dartmouth. We stratified the procedure as well as the patient, and then took on the emergent, urgent procedures. So our volume was way down as well.
Thank you. So thank you for that feedback. I think we all learn from each other, and I believe that going forward, COVID is probably not going to devastate the pain service to the same degrees that it did, as it probably will resurge later on in the year. I think we're just better prepared. But I'll pass the microphone to Dr. Mehta to focus on career planning and pain medicine as a specialty postgraduate. Neil.
Thank you, Chris, and thank you, panelists, for a very interesting and exciting discussion. In the last webinar that we did, we talked about changes in the time of COVID. I think these panelists have already done a great job of highlighting those changes that they're making. So I think this is a great opportunity for the panelists to reflect and share what they give as career guidance to their fellows and how they see the practice of pain medicine evolving sort of over the next 10 to 20 years. And I'd love to hear from each one. Dr. Ashburn, maybe you can lead us off.
Thank you very much. I actually think that we're in exciting times and that we have signals that we're going to be developing new therapeutics. We have increased recognition of the role or limited role that opioids play and a focus on improving the value that we provide on either integrative care in patients undergoing surgical procedures and those patients who have spine disease or chronic pain. And I think that many programs that are looking towards value-based reimbursement programs, which I think are going to become more prevalent rather than less prevalent, is both going to be a challenge and an opportunity for pain specialists. The challenge will be is that we're going to need to continue to build our evidence-based with regard to demonstrating that what we do actually adds value. The opportunity is that I actually believe that what we do adds value, and I believe that there's some growing opportunities, particularly with complex patients who are undergoing painful procedures and elective surgical procedures, that we actually have a role in trying to prehab those patients and get them ready and improve their surgical outcomes. And we certainly have a role in taking care of the complex patients after surgery. And I think it's going to be up to us to start demonstrating through the collection and reporting of patient-reported outcomes and other measures of what we do, that what we have and what we offer adds value as an institution. And I think that those pain specialists that are truly focusing on offering specialty care within an integrated system focused on the patient, looking at evidence-based care and working.
Great, well, thank you. Andrew, maybe you can tell us what you give guidance to your current and graduate fellows.
Well, pain is clearly different than when I came into it in 1993, where we had very limited tools to use. There's just ever expanding, devices and things that we're doing. So I always tell my graduates that this is a base. This is what you've started with, but you need to continually keep an open mind. Things are going to be continually evolving, and you need to embrace and adapt that. You can't just stay in one spot. In terms of how we're affecting during COVID, it's going to be with us for a while. We've all adapted. We're going to work around that, but people are still going to come in with the same issues and problems. We may be seeing some new issues, as we've all just mentioned, but we need to always be keeping that open mind. It's still a very exciting field. I still feel that in my lifetime, I'm going to see pain management not as just a fellowship, but almost a separate residency. I've always felt that there was a strong need because people are going to work with this, and I could clearly see it as being a 3-year residency evolving on its own. So I don't know other people's feeling on that, but fellowship is just 1 year. It could it be 2 years? It could be, but I don't think we need to at this point. But I would endorse it maybe if it wanted to become a separate field in and of itself.
Great. Shravani, maybe you can reflect what you share.
So a few things. So pain, like I would agree with some of those sentiments. Pain is relatively new field, right? So it's only been a specialty formally for about 40 years. And because of that, it's a little bit different than some other specialties. It's constantly changing. You know, since I've gotten out of training, there's already been like several new technologies that have come out. And you just have to be a learner always and on your feet and willing to expand and grow your knowledge base. And to me, at least, that's exciting. There's a tremendous opportunity for those who are involved in research or interested, just because it's evolving and it's expanding and it's young. And that's also very exciting. I would say that one piece of advice I would have to those going out into practice is, you know, just don't get too hung up on that first job. So if it works out, great, but it may take a little bit, it may take like 2 to 3 years for you to really figure out what you want to do, and that's okay. So I think when I was looking into this, I found the statistics like 80% of pain fellows, like when you come out, your first job, you're going to change within the first 2 years. And I think that's really okay. So, you know, when you're looking for a job, especially with COVID related challenges on all this kind of stuff, don't get too hung up on that first job being absolutely perfect. If it is, it's great. I'm still at my first job, but it doesn't have to be that way.
It's excellent advice and very true. If we look back at our fellows that have graduated, it always amazes me how many have changed and even potentially started their own practices. So thank you for sharing that.
One
Dr.
other
Sevilla.
thing,
Oh, I'm
sorry.
sorry. Yes.
This just came to mind, but I also think as pain physicians, we're in a very unique place to contribute to policy. So, you know, with the opioid crisis and even some of us have a background in anesthesia. Now that's very relevant during COVID-19. A lot of our expertise is really applicable to what's going on in the country from a public health perspective. And I think it really puts you in a unique position to contribute nationally to what's going on. And that's really pretty cool too.
Great. Dr. Sabia, maybe you can reflect your wisdom you've shared with your graduates.
Sure. So with Cooper being a level 1 trauma center and some novel therapies in the pipeline, we're seeing a better survival rate with some of these tragic traumas, and cancer survival rates are better. So there will be no shortage of patient flow in chronic pain. So the future is bright with that aspect. And with other drug developments in the pipeline, as Dr. Ashburn said, and other technologically devices with STIM advancing and Vertiflex on the market, I think the take-home message there that I'm echoing with my colleagues is adaptability. You have to be able to adapt. And 15 years ago when I did my fellowship, it was prescribe opioids, titrate up to side effects, and when the side effects came, treat them. Now it's a different method. We realize that plan A didn't work as well, and we have to use this multidisciplinary, multimodal approach. And some of these patients are surviving traumas that we never thought they could, and it's being our creative minds to help live them, give them as much of a normal life as we can. That might be with a prescription, along with therapy, along with an intervention, along with behavioral therapy, using all the tools in our toolbox, really. So that's our best advice, is being adaptable, keep an open mind, as my colleagues had mentioned.
Great. Dr. Dent, maybe share with us what your thoughts are.
Sure. Yeah, I would agree with everything that's been said so far. And we have lots of conversations with our fellows, and I really try to get down to, you know, what their passion is when they're beginning to narrow down their search for jobs. And what do they enjoy doing? What do they do well? You know, what areas would they want to be in? And then really trying to hone down on specific jobs or job markets. Then get them out there talking to people that are out there actually doing those jobs, and seeing, not just talking to one person that was in private practice or academic, but talk to a lot of people. Talk to as many people as you can, and we'll connect them with these people, just to get an idea of what the day-to-day life is for that provider, and does that fit with what you would want in your career. And I would echo that you don't have to hit a home run with your first job. You know, not many of us do. Use that job as a springboard to what you are actually passionate about, and then go for the not say the perfect job, but the job that's what's unique for you.
Thank you. So we are winding down, and I want to share my thoughts on you know, the COVID era training. Many of us have seen practices that basically crawled to, you know, to their knees during the peak time. For the fellows that are, or the applicants that are listening, it was a hard time, but our fellows got through it, just like I know that the fellows at all the panelist programs, they use tools that we didn't think about before, like simulation and a lot of techniques that they practiced outside of patients to really continue their skill building. And I think that we all are looking for the next wave of teaching and learning that is sort of beyond what we used to do. I want to thank our panelists for joining us. We will continue these sessions. We actually got, we got a question come in. We have a question about rotations, elective rotators this cycle. And Dr. Dubakla talked about that they are allowing some rotators. Are the other programs allowing elective rotators this cycle? And you can just answer yes or no.
I'm sorry, do you mean from another institution? I'm sorry.
Correct, yes. Sounds like
Right now,
elective
the
rotation.
policy for, unfortunately, the policy for NJMS is they're not allowing anyone from an outside institution to come in right now because of COVID.
Same thing for Penn.
Same at Cooper.
Same with Dartmouth.
I will add that I think all of these policies are just subject to change based on what's happening in the state. So Baltimore just announced yesterday that they're closing down indoor dining, and there's a new mask rule. And so this stuff is all constantly changing. So if you're interested, I would say check back at the time that you're actually looking to do that.
And perhaps, and Cornell is also close to this, but we have found that unless there's a really strong intellectual curiosity about the program or meeting the faculty, that we don't view it any differently for someone that doesn't come to join with us. And I think that the panelists will probably agree with that. So don't lose hope about the fact that you haven't been able to do that. So we are going to continue these series. We have another one in a few weeks, again with panelists from the program. We thank everybody for joining us. I'd ask that we continue to stay on and join us to watch a demonstration from our sponsor, Allergan, who has been kind enough to show us how a migraine treatment through Botox can be performed. And we are, again, thankful for their support so we can run this, this program. The Eastern Pain Association, for those that don't know, is one of the oldest pain societies on the Eastern Seaboard, and one of the smallest. But between the leadership of some of the past few presidents and our current president, Dr. Garibo, we are excited to see a resurgence, especially with some of the younger faculty that have joined our group. We invite all those that have viewed this today to join us. We are offering free membership into the group. We are a very small but family-oriented group in terms of getting to know each other. We would like to continue to engage with you. With that, I wanted to check in and see if Michael Barnard was ready for us to show this.
Yes, can you hear me?
Yes, great. Well, thank you. And we will allow you to take over, and I ask our panelists to mute if they can.
Yeah, I just would like to wrap up. Thank you, our program director, panelists as well, for sharing their perspectives. I believe that our audience and even the program directors themselves all benefited from the exchange. Thank you for your time.
Okay, can you guys, I just want to make sure that, can everybody see the model before you mute yourself? I'll take that as a yes.
Yes, we can. Thank you.
Okay, so I will start. Good evening, everybody. First of all, I want to thank the Eastern Pain Association for allowing Allergan to have this opportunity to review the Botox chronic migraine. for patients 18 years of age and older. Just a few key points before I get started. The paradigm consists of 31 sites across 7 head and neck muscle areas. Each injection that we will do is 5 units of Botox for a total of 155 units, and you will always use a 30 gauge half-inch needle. Patients should be retreated every 84 days, always injecting the whole paradigm. And while injecting, it's always important that you're aware of the angle, the depth, and exactly the dose that you're giving, that the dose is always 5 units per each injection. Just one more thing, due to time, there are some insights and considerations that I won't be able to cover. So if you're interested in learning more, please email me and we will have your Allergan representative call you and they can come in and give you a one-on-one training, either live or during COVID times. We also are doing it Zoom just like this with our model. So we'll go ahead and get started. And the first muscle that we inject in the paradigm is the corrugator muscle. The corrugator muscle has 2 injections, 1 on each side of the forehead, and it's for a total of 10 units of Botox. The way we localize the corrugator muscle is we place our thumb on the medial aspect of the orbital bone, and we ask the patient to squeeze their eyes tight or furrow their brow, and we look for the bulkiest part of the muscle that's easily palpable, and we pinch that between our thumb and our index finger. And I'll go ahead and mark that approximately where that could be. When we inject the muscle, we go on a 90-degree angle and we inject the superficial aspect of the muscle and we go 5 units of Botox. We then will repeat the bilateral injection on the opposite side using the same localization technique. Once that is done, we'll move on to the procerus muscle. The procerus muscle, the base of it is located midway between the 2 corrugator injections. This is also a superficial injection and given at a 90-degree angle, 5 units. Once we've completed those 2 muscle areas, we move on to the 3rd muscle area on the front of the forehead, which is our frontalis muscle. The frontalis muscle has 4 injections, 2 on each side, for a total of 20 units of Botox. To localize the first injection, which we call the medial injection, we go vertically up from the first corrugator injection in the upper 1/3 of the forehead. The second injection is located 1 finger breadth lateral from the first injection, and it's also in line with the edge of the cornea. The injections are done, these are done on a 45-degree angle with the needle facing upward towards the top of the head. And it's also important to remember, if you can, to have the bevel of the needle up. And we give 5 units into each injection. And then we'll repeat the other 2 on the bilateral side, same localization techniques. So now we'll move to the side of the head, which we label our temporalis injections. I'll make sure you can see it. And the temporalis injections are all given within the hairline. The 2 landmarks that we're going to use while we localize these is the tragus of the ear and what we call the superior helix of the earlobe, of the top of the ear. What we want to do is find the tragus and go vertically up the side of the head, 2 finger breaths, and that'll be our first injection point. The second injection is located 2 finger breaths still in line with the tragus above the first injection. For the 3rd injection, we localize 1 finger breath forward to the front of the face and in between the first and second injection. And you'll see we form a triangle. Again, we're in the hairline. For the 4th and final injection on this side, we go 1 finger breath posterior from the second injection. And this is in line with the superior helix of the ear. When we inject the temporalis muscle, We want to go on a 45-degree angle with the needle always facing posterior from the front of the forehead, and it's superficial. And again, 5 units in each. We would then repeat the other 4 temporalis injections on the bilateral side, same localization technique. So when we're done, we've given 40 units of Botox, 5 units in each injection for the temporalis. The last area is the posterior injections. The first muscle area that we inject is the occipitalis area. This area consists of 6 injections, 3 on each side, for a total of 30 units. The areas that we want to use to localize these are the mastoid process behind the ear and the inion. The inion is the most palpable and posterior portion of the occipital protuberance. I've labeled the occipital protuberance here approximately. So above that, and the most palpable part would be the inion. You want to place your thumb on the inion and your pointer finger on the mastoid process. And you'll find a midpoint between those 2 locations. And that is your first injection. The second injection is 1 finger breath diagonal from the first injection at the 10 o'clock position, and 1 finger breath for the second injection diagonal from the, for the third injection from the first one at the 2 o'clock position. So as you can see, we formed a V. These injections are also on a 45-degree angle, superficial, and each is 5 units. And then we'll repeat the other 3 on the bilateral side, same localization. The 6th muscle area is the cervical paraspinals. We're going to give 2 on each side for a total of 20 units. And the area that we want to use to localize this is the occipital protuberance again. What we'll do is we'll take 2 fingers and we'll go from the base of the occipital protuberance. And then I'll take from the bottom finger, we call this our no injection area. So where my second finger is, I'll find the midline of the spine and go about 1 finger breath off the midline. The second injection is 1 finger breath on a diagonal from the first injection, and it's also in line with what we called before the superior helix of the ear. This is given also on a 45-degree angle with the needle facing upwards, 5 units, superficial aspect of the muscle. And then we'll repeat the other 2 on the opposite side, giving the same localization, 5 units in each. One other thing to note, when you're doing the occipitalis, the cervical paraspinals, it's very important that the patient is in a neutral position without the head forward, so we don't go too deep and possibly cause some neck weakness or neck pain. So the best thing to do is have the patient sitting in a chair in a neutral position. The last of the muscle areas is the trapezius area. The trapezius injections, we want to find the AC joint and what we call the necklace line or the inflection point. We'll place our pointer finger on the inflection point and our thumb on the AC joint. And the middle point between those 2 is the first injection. From there, for the second injection, we'll find a midpoint between the first injection and the AC joint. And for the third injection, we find the midpoint between the necklace line and the first injection. These injections are given on a horizontal axis, about 0 to 10 degrees, in what we call the supraclavicular portion of the muscle. And we give 5 units in each. We'll then repeat the other 3 of the 6 total injections for the trapezius on the bilateral side, again for 30 units total of Botox for the trapezius muscle. So when we're all done, we've done 7 head and neck muscle areas. We've given 155 units in 31 different sites. And that completes the paradigm, which usually is done in about 10 minutes. So I'll stop, and if anybody has any questions, I'd be happy to answer them.
Thank you. That was very, very informative. And again, thank you to Allergan for taking the time to demonstrate this and to share how migraine headache can be so impacted by this. I thank all the panelists again. I thank you to our attendees. There was one final question about pain fellowship. Is it limited to anesthesia, PM&R, neuro, family, ER, other backgrounds? And I would say that most programs are open to reviewing applications from a lot of specialties. So thank you again, and we hope to see you on the next webinar.
Thank you.
Thanks. Good luck to all of you.